can put it up on our blog. So good morning. Welcome to the Medicine and Society Mashup, which is basically the Medicine and Society Minors Monthly panel of experts and activities to kind of focus on the relationship between social values, social forces, and biomedicine and healthcare. So we'd love for you all to join in the conversation today. We have a fantastic panel of experts. Hopefully Bethany will get here. I want to thank Dr. Katie Powell for co-sponsoring this event on behalf of the Center for Refugee, Migrant, and Displacement Studies. So this is partly Science and Technology Studies, which is my department, and partly Center for Refugee, Migrant, and Displacement Studies, where Katie directs, and I'm an Associate Director of Education there. So in order to get started today, I want to go ahead and introduce our speakers, and then I'm just going to turn it over to them to be able to talk about what they do. So our first speaker is Dr. Eva Stitt. She's a refugee mental analyst with the Virginia Department of Behavioral Health and Developmental Services. She's a member of the Refugee Mental Health Council and a strong advocate for refugees, migrants, and displaced people. She's been a wonderful partner to us. And I'll let her say a little bit more about herself and her work, but I can say she's an expert in the field and really a game changer for the state of Virginia. Our second speaker today is Catherine Randall. She's a PhD student in rhetoric and writing at Virginia Tech, and she's also the medical coordinator for the Blacksburg Refugee Partnership. And our third speaker, hopefully she'll show up soon, is Bethany Lackey. She recently received her PhD from Virginia Tech. She's currently the director of the Roanoke Refugee Partnership and a licensed professional counselor. She's passionate about finding gaps in mental health care within communities in order to organize solutions. Dr. Lackey specializes in trauma and is the co-owner and counselor at A Tree Planted. And it looks like she's just coming into the waiting room, so we'll let her in and we'll get started with the panelists. So maybe, hi Bethany, welcome. Hi Ashley. So Eva, you want to get started and tell us a little bit about what you do and say a few words about refugee mental health. And again, for those in the audience, please feel free to treat this like a conversation more than a formal presentation. So go ahead, Eva.
Thank you, Rebecca. And I love it when it becomes a conversation because it's really for us to learn and get connected. It's got to be your idea and our idea put together. So my name is Dr. Eva Stitt. I work with the Virginia Department of Behavioral Health and Developmental Services. I manage the Virginia Refugee Healing Partnership, which is focused really on refugee mental health. But in order to deliver that, I'm working extensively on language access because many of our refugee and immigrant populations, that's the very, very first problem when they cannot communicate, or if they communicate, it is not understood well. Now we are creating more problem than the first problem. So I'm really very strong advocate for language access. The second program we focus on is on trauma. We know that based on a triple trauma paradigm, most refugees and immigrants go through these 3 stages of trauma. Trauma before leaving the country, trauma going into another country, and trauma coming into the United States. They are just different, but they're all traumatized in some way. And the last focus of my program, Refugee Healing Partnership, is on prevention. We truly, truly believe that we can address some of these, but the best way is really to do prevention work. And we are big on community-based prevention program. And I'm looking forward, I can share with you what we can do, and you can help me with this.
Thank you, Eva. Katie, do you want to go? And then Bethany, I'll give you an opportunity to introduce yourself and talk about your work.
Yeah, thanks. Like Rebecca said, I am Katie Randall. I am a PhD student here, and my research focuses on health resettlement for refugees, and specifically how health communication happens with community resettlement volunteers. And that ties into my volunteer work with the Blacksburg Refugee Partnership, where I have been a medical coordinator since 2017. And what we do, and what I do specifically with the Refugee Partnership is as a medical coordinator, I've been involved both on the kind of the family level, where I'm helping families make medical appointments, follow up with long-term care, manage medications, finding interpreters for mental health appointments and other kinds of health appointments. And then more on an organizational level, where I've interfaced with the Department of Social Services, talking about Medicaid access. And what's come up with that, and this builds perfectly on what Eva was talking about with that 3 kind of different traumas. There's the idea that when refugee background folks are resettled in the United States, that they're only processing the trauma of what came before. Like, oh, it's so sad that your country, it had these horrible things happen to it. And like, weren't your living situations in the first country you went to so horrible? And a lot of people, at least members of the community, aren't thinking about the trauma of being in the United States and what that means. And there's a lot of outside of just what happens in the clinical setting. And we know this, that there are social determinants of health. And this plays a huge role. And this is backed up by research and also my own experience as a volunteer, where your housing, access to housing plays a big part in mental health. Access to food and safety are big determinants of mental health. And so the language barriers, absolutely, and trying, like that Eva had talked about, and trying to get that interpretive service and trying to get that, remove that barrier to care, but also understanding that there are these other power dynamics in play in resettlement trauma. And we, like, for instance, we had one family who was initially resettled in Roanoke, and they were in a very unsafe living situation. It was very unclean, and they appealed for help to different organizations, and no one would help them move. And the one of the members of the family said, "I would rather go back to Lebanon and deal with and live in a garage in Lebanon than live here, because I can't handle the stress of this." And so there are lots of things going on the community level and the community setting outside of just that clinical interaction that are contributing to trauma that need to be addressed. And we, with the Refugee Partnership, one of the nice things about having that kind of organization is that you can establish these more social networks that are where I don't have a medical background, but I'm talking to therapists, I'm talking to doctors. And we're kind of in a collaboration of what needs to be addressed outside of the clinical setting, what needs to be addressed inside the clinical setting. How can we tackle these barriers together as kind of a networked team, as a community? And so that's the approach and the position I'm coming from to this, is not as a medical professional, but as someone who is seeing what happens outside of that setting, and seeing those kinds of difficulties and how they affect mental health.
Thanks, Katie. Go ahead, Bethany.
My name is Bethany Lackey. I just finished my PhD in counselor education and supervision at Virginia Tech in December. And my research focus was on refugee mental health, but more specifically, I was interviewing counselors who see refugee clients, because I wanted to identify their gaps in education. I wanted to know what was really helpful for them and what they learned, both educationally and professionally along the way, that really helped them prepare to see that population. And I identified a lot of different things. And the reason that I wanted to focus on that is because a lot of the research focuses on barriers for the population instead of, all right, what are some of the answers that we can come up with? How can we work together to find solutions? So I really wanted to head in that direction of finding solutions to some of these things. And I think it starts with not just identifying the problems, but then identifying the more systemic issues. Where are the gaps in our education? How can we fill in some of those gaps. So it was talking to them about barriers, yes, but also education that they wish that they had, or trainings that they wish that they had, knowledge they wish they had before seeing the population. So now I have these data, and what I really want to focus on is advocating for, this goes right along with what we're already talking about, advocating for language access, working with interpreters, not just having the curriculum. How can we apply the curriculum? How can we make sure that there are chapters in every counseling textbook that talk about working with interpreters, so that it is not some sort of specialty to work with someone who is an English language learner, but that it is a common part of their education, that they would learn how to work with interpreters and all of the different aspects that come along with that, because it's not just calling and getting an interpreter. There are so many fine details in language access for mental health. That's my next focus, I believe. Also, I am the director of Roanoke Refugee Partnership, which is a nonprofit here in Roanoke. And I helped establish that nonprofit in early 2017. And we have so many volunteers now and people who came out from the community who wanted to be helpful. So we are working with people to do tutoring programs. We have a summer learning program for kids to make sure that they stay caught up with all of their work and help them, again, with language. We are also sort of a hub for resources. We help connect people to whatever they might need within the community. We provide mentors for families to help them with access to different resources as well. I'm the co-owner of a Tree Planted Counseling here in Roanoke, and we have established our practice as a nonprofit as well, because our overall mission is to also find gaps within the community. We want to conduct research, gather data, to go out and see what we're missing in mental health and how we can be part of the solution.
Thanks so much, Bethany. So I don't know if people that are not on the panel have any questions or comments that they'd like to make, or things that they'd like to ask. I'll let you have an opportunity. I've got several questions I can ask, but I wanted to give everybody else an opportunity if they wanted it. Okay, so one of the reasons that I put this, oh, go, Katie, go ahead. Go ahead.
Katie, you're muted.
Thank you all so much for being on the panel. One of the questions I have is what would be what Bethany was talking about, kind of barriers and solutions. What are some of, can you say a little bit more about that, and about how part of your work includes communicating with people who are in positions like yours across the state or even across the country, and how you find out about other kinds of solutions? Like, what are the ways you come to those solutions, and how are the clients that you work with part of those solutions?
Sure. I'm thinking about this from a lot of different angles and several different hats that I wear. But yeah, so much of the research is barriers. Here are the problems. Here are the problems. And so when I was saying that RRP is a hub for resources, a big part of that is connection to other people within the community. I believe that it is often the case within nonprofit work that there is, how do I say this? There is fear of sharing. It's sort of, there are only so many grant funds out there, so are only so many grants that we can get. And so there, it, I think, comes down to more collaboration between people who have the resources and connecting them to people who need the resources, and connecting clients, finding out what clients actually need. A big part of the research that I did, what a very common theme was not to make assumptions. It's to work with the person right in front of you, not to make assumptions about what this person needs, whether it's in mental health or whether it's the resources that they might need at the time in meeting their basic needs. It's going to the person. We always do a needs assessment with them instead of making those assumptions or talking to other people who might know the family. It's going in and talking to the family and asking them what their actual needs are and what they believe they might want in order to move forward and increase their upward mobility. And so it's working with them in that way. And then connecting and collaborating with different organizations. And then broadly, nationally, I believe one really simple thing to do that has been incredibly helpful that we don't do enough is look for the processes that work. Who's already doing this work? Where is it working? How is it working? And looking for people who have already done this work and are doing it well.
And pinging off of what Bethany was talking about, I think a certain amount of flexibility is really helpful. Recognizing that the models that people are used to or assume are helpful may not be what people need. One of our most, I guess, successful interactions with a therapist here in town and a refugee background person was when the therapist actually met at like a coffee shop with like not just an interpreter, but a couple other like men who were also like friends with the person, and it made it seem like less like a, you know, you need to talk to a therapist and more like we're doing this as more of a social interaction. And that was that had been led by the refugee background person. And that was what he was comfortable with. A lot of times we've experienced with the Blacksburg Refugee Partnership where someone says that, you know, they're not opposed to that kind of like therapy. And then after that first meeting, they're like, I don't understand what that was. Like, I don't understand why I was talking to someone. How is that supposed to help me? It was just very strange. Like it's a new interaction that's not explained thoroughly and it's not adapted to what that person needs or wants. And so I think having that ability to be flexible and to adapt, there's a term that I've seen go around the literature that's not just like cultural competency, right? And Rebecca, I know you talk about a lot about this in your work, right? It's not just cultural competency. It's not just knowing, like assuming that you can know enough about a person's culture to provide the appropriate care, but a culturally safe interaction, right? Having an interaction that's led by the person that makes them feel in control of the situation, safe enough to speak and to advocate for themselves. And I think you only get that if you're willing to be adaptable to that.
I will add that those culturally safe interactions are so empowering too, right? That I believe that is a part of our work is that empowerment and using the privilege that we have in order to give the person autonomy, because so much a part of the process, Eva outlined sort of the process of being in the home country, then being, you know, in transit or being in a refugee camp and then being resettled in the United States. And so much of that, people have very little control over what's happening in their lives. They don't even have control over where they are resettled. And so to get here and then have someone say, you have autonomy over your interactions here and what you want for yourself is incredibly helpful and empowering.
I would like to piggyback on what Bethany and Katie had mentioned specific to culture. And I truly believe that, you know, you can take the person out of the culture, but you cannot take the culture out of the person. And even if they are already here in the United States, they bring within them mentally, emotionally, physically, their cultural view. In short, when it's their first time to know that there is such thing as narrative therapy, they kind of, even if we explain them, it's hard for them to understand, because for them, if they have mental health issues, like for example, depression, they don't talk to anybody. Instead, they use physical means. They express it using their physically. So they go farming, they go hard labor, putting on themselves something to express that negative feeling that for us, we might label depression. Here, we don't. We go to a room and we talk. And so that cultural component makes a big difference into how our refugees and immigrants are able to correlate how we treat their issues. You know, the other part about what Bethany and Katie was saying is that we are talking about culture in relation to the person. And so even if they both came from the same country, which our refugees came from all over the world anyway, so we cannot just generalize and say, oh, this is a refugee, these are the big issues. That's not really very, very true, because out of the big culture, let's say even from just one country, there could be tribal culture, there could be religious culture influencing certain aspects of their lives. There could be community culture, there could be personal culture. So what Katie and Bethany had said, we really need to take time and ask. And that's the only way we will find out, because all other interventions and treatment we do means nothing to them if they cannot relate to it. And basically the only connection we have is culture. We can provide intervention for language barriers. Say we try to get the best interpreters, competent interpreters, which is one of the things we're lacking. And I'm glad Bethany is able to look further through her dissertation. But when it comes to culture, unless that person says it so, we really cannot know it. In nursing, we say that the only way you'll find out is ask. But it takes time, and that time is an investment.
And I have one more thing to add to that. Not just like an investment in the, like recognizing also, like for when refugees come here, there's only that initial mental health screening, and then there's really very little like follow-up on that. So recognizing that, oh, it may take a while for people to feel safe enough to bring up, you know, feel physically safe enough to bring up certain issues. And so that takes quite a lot of time also.
Mm-hmm. And the safety, we're talking about safety component. Imagine having to flee your country of origin because of government issues and being forced out of your country, and then having to establish safety in a brand new country under a different government, right? And so gaining or getting access to those resources might mean sitting down with someone and not understanding why they're asking you the questions. Am I going to get in trouble if I say I do need help, or that I'm struggling with my mental health? All of those components of safety are important too.
So thanks, yes, to all of you. I have a question. This presentation is really often, our Medicine Society mashups are directed to pre-health professionals, so the undergraduate students who one day want to be like you all. And many of them want to go into medicine or public health. And I wonder what you would tell them in terms of the importance of attending to mental health and thinking about the overall health of someone, especially with regard to trauma, and then also about the relationship between the embodiment of trauma and health outcomes. So how is it, we're talking about mental health as if it all happens in the brain or the mind, but we know that trauma becomes embodied and has other manifestations. So what do you think that pre-health professionals should know about that relationship, and what should they keep in mind when they are working with diverse populations who have gone through trauma?
Oh, I would like our clinicians to speak first.
Okay, it's hard to know where to begin when talking about trauma, but I think, Rebecca, I think that you prompted well in talking about how trauma lives in the body and it's not just in the mind. because so many people from refugee populations will come into the doctor's office and say, I'm having this problem, I can't figure out where it's coming from, because it is like stomach pains or tension or some sort of embodiment of that trauma that hasn't been processed yet. And so that's the first thing. I always recommend The Body Keeps the Score, which is a wonderful book that explains trauma and the body, how it works, and gives some great examples of how it works in the body and the brain and those connections. I think education around trauma and explaining trauma as a part of physical health to populations who might have increased stigma against mental health is important, and explaining it in a way where it's like your brain is a part of your body, right? So when we're talking about physical health and taking care of your body, you also have to take care of your brain, which is running the rest of your body. And so if you're holding onto trauma, what your brain is doing is operating in that fight, flight, freeze, or fawn responses all the time. And so you're always running on adrenaline. So explaining that in a way where it's a part of physical health, how the brain and the body are connected, in order to take away some of that stigma of discussing mental health, and a way of treating the body symptoms of trauma by treating mental health in your brain. I think that's a good way to begin, is sort of that education between the body and the brain link. I could go on for days, but I want to make sure I'm leaving room.
Yeah, and I would say, I mean, it's not, I guess it's kind of like the other way around of what Bethany just said, where it's not just like treating, that the mental health treatment affects physical disorders, but also your physical situatedness affects your mental health, right? And this goes back to what I was talking about before about, you know, the research with refugee background folks shows that it's like the social and material conditions in which you are resettled affects your recovery from pre-migration traumas, migration traumas, and post-migration traumas. And so having, when you're considering this embodiment, right, it means that the physical and material conditions in which people live cannot be separated from your work as a mental health clinician or service provider, right? And so I know sometimes, well, there's this ongoing conversation about where should be the line between being like a doctor or being a medical professional and being like an advocate, right? And being an activist. And some people are very squeamish about crossing what they see as a line into activism. But I think if we're going to acknowledge that this is all one big thing that has to be treated all at the same time, right? You have to acknowledge the power dynamics in which refugees come into the United States. Like I had one of the women I worked with when Biden was inaugurated, and she was telling me, she calls it tension in her head. She has really bad migraines. And she was like telling me about how her tension was so much less now that Donald Trump wasn't in office anymore, because she had lived in this like just state of stress that had really affected her mentally and physically. And so acknowledging that that's, I guess, talking to students who want to be medical professionals, right? There has to be, you can't just deal with like the one person in the one setting, right? You have to also acknowledge the larger power issues and disparities and marginalizations, and how those are affecting the people in the community that are being resettled here.
Yeah, I cannot say more, but for future professionals in the field, I'd like you to look back to this year where COVID has an outbreak, because that by itself will tell you how much mental health is needed in the future. What our kids has experienced today may not significantly manifest in their young life, but the studies on adverse childhood experiences, we know that in those years, kids will have shown this trauma experience in the future. And we know mental health is not just for kids, but from 12 years onward, it becomes very, very significant. With young kids, we cannot see it right away because it's more of how the parents would look at it. The kids will not report to you that they are depressed. A 5-year-old kid will not tell you that. But when someone gets into like 12 years old onwards, it will start to come up. That's why we have a lot of issues in middle school and high school at the moment. But we expect, from the perspective of my department, the Virginia Department of Behavioral Health and Developmental Services, we are talking about how to prepare, but most importantly, how to prevent this impact of mental health, this impact of COVID on mental health. So for adults, we are kind of very, very aware right now, but for kids in the future, and I put them in your hands because you will be the future, you will be taking care of them. Just know that whether you go onto the medical or the behavioral health, it will have an impact. And as far as the impact of trauma, let me just illustrate to you in a story. So let's say here's the person, or a refugee or an immigrant for that matter, with high risk for trauma. This person was not diagnosed to have mental health issues, trauma issues, or he's just one ordinary individual like you and me. But we kind of put this person into a job and he cannot hold jobs more than 5 weeks. There could always be an issue. It's either it's late or not able to understand, not able to retain instruction. So what happened then? The very essence of why they would survive, which is the economic essence, is already disruptive. And if we look into person unable to hold jobs, then somebody has to take care of, to pick up where that person was not able to do. And so it changed the dynamics in the family. Kids will be affected, the wife will be affected, the whole family is affected, the community is affected. And now we're looking into public health issue. I'm not just talking about one person, because there's too many of these people are of the same situation. They are not just well attended to. They look at it, like Bethany said, as a physical health issue. Like they have stomach ache all the time with no significant cause. They have not found any significant cause or a medical cause. Why is there so much migraine? Why is there so much issues that they cannot keep repeating physically? So in short, the story of one individual experiencing trauma, but is not led into a proper treatment program. Let's say we just look at that person in the health or medical aspect. It will continue to go on and on and on until such time that it becomes so disruptive in life. And that's where we have already serious mental issues. So I would suggest that for young professionals or would-be professionals in health and mental health, which I would really encourage you, go for it. Yes, go. Please look at what happened with COVID, relate it on its impact to the kid and the future.
I would like to quickly add on this subject of trauma that all of the counselors that I interviewed for my dissertation study made a point to not make assumptions about PTSD. And while most people who are from refugee backgrounds have probably experienced trauma somewhere along the way, it's important to first look at their hierarchy of needs. So when they are first resettled here, they might not be in the position to process trauma. It's important to establish safety before processing trauma. And safety comes with stability and stability is really difficult to find within that first year. So it might be a while before someone is ready to look at trauma. And also the assumption that someone comes into counseling is that's a fallacy in itself, that a person of refugee background comes into counseling to work on trauma. And so counselors might be pushing, like, I know you've been through these traumatic experiences, but the person in front of them is saying, I'm just trying to figure out how to buy groceries for my family, right? Like meeting someone where they are on their hierarchy of needs before assuming that it's time to process trauma.
Yeah, and the way that resettlement works in the United States absolutely works against that process too. There has been work done on the expectation of economic self-sufficiency, the fact that we expect it so quickly, that we only provide financial and material support for under a year. You only get a caseworker for 90 days. You have access to, refugee health, like cash assistance or health medical assistance for 8 months. And that causes a significant amount of stress that certainly exacerbates that trauma that Bethany is talking about, where it's not a trauma of like, yeah, your country was bombed, but it's the trauma of like, how is my family going to survive here? And so that on a policy level too, certainly has mental health implications.
Yeah, I always would describe that refugees coming to the United States, where they come from, it could be a jungle of trees and animals. And when they come to the United States, it's a jungle of buildings and cars. So it's still, they're navigating through a jungle, and they need someone like volunteers, for example, or clinicians who can help them get through that jungle, whether they're thinking about their past and their lives and the jungle that they're trying to navigate right here in the United States. It's really, really hard when all of your life you're buying things by piece or by groups. And here we talk about pounds, and you kind of expect, they're kind of shocked and doesn't understand why we put it by pounds. And there was no, things like these are different. They cannot even find what they're looking for. Let's say baby food or milk, baby's milk. They cannot find the grocery store because our grocery store is bigger than the town hall probably. It's huge for them. It takes them sometimes to understand how to locate food. And even if we have so big shopping centers and grocery stores, it also very discouraging not to find the food or the ingredients that make you feel at home. So they are not able to eat their food. They are not able to cook their favorite meal. Festivals, birthdays, occasions, that is important to them as well. And they'd like to serve their own delicacy, but they cannot find, they don't know where to find those ingredients. And so, yeah, we have so much, but it's not what they want. It's not what they need. So if you just put it in the context of how people would feel if they don't feel at home, then there's a lot to speak of.
Thank you. So there's 2 comments in the chat about grief and grieving. And I'm wondering if you all can speak to that, specifically with the 3 stages of trauma that you mentioned, Eva, but also just kind of the broader process of grieving that goes into being displaced and then resettled somewhere else.
Grieving is a process. It's a worldwide concept, but how we grieve is very individualized. So even within families, we grieve differently. Let's say a refugee leaves their country of origin, their space, with probably no warning. whatever they have on their body, that's all they carry with them, fleeing to a safer place, probably the next country. So in terms of grieving, there's a lot to grieve, not just losing what you have, but also the relationship. Part also of grieving is not knowing whether members of your family are still alive. That still hurt, you know. So grieving is not just losing someone, it's also not being able to know where your loved ones are. And a lot of our refugee and immigrant populations are in this situation. Like, for example, our current problems with unaccompanied minors. You know, there's a lot that they lost, not just the physical things, not just the financial things, but the emotion that's really not expressed because it cannot be seen. We can only feel it and know it if they start talking about it. So that's just, you know, a little concept of grieving from, you know, not the death, the physical death, but grieving in the form of what you lose, and with a concept that you may not be able to recover uh, uh, of uh, of that loss.
Yeah, and that's absolutely something I've seen in my role as a volunteer too, right? When we're talking about the kind of the stages of pre-migration and then country of first resettlement and then here, but they're not experienced as concrete and discrete stages, right? There are threads that run back to all of them. One of the women I've worked with has family back in, her home country who are regularly experiencing violence. And so like Eva was talking about, it's not that they've like died necessarily, even though that's not an uncommon thing to have your family members die in the migration experience. But they are, it's the, I don't have the expertise to call it like survivor's guilt, but that's what it sounds like. Like there's a heaviness of like, I'm here and they're there and they're being punished for me escaping, or they're experiencing violence and I'm not. And I don't, and you have to leave your home that was sometimes like an ancestral home, right? That your parents and your grandparents lived in, and all of you lived within a couple blocks of each other and you all saw each other. And now suddenly you haven't seen your family in a decade. And you don't know when you'll see them again. And you may not know where some people are, or some people may have been resettled in Germany and you got resettled here. And you don't know when you'll be able to bridge that gap. And so the family connections seem to be a very big part of the grieving process, is that loss of connection, that loss of like a home place, like a gathering place, that familial community is really hard and doesn't like go away. Like it's not like if you get adjusted to life in the United States, like that grieving process isn't over.
And Rebecca, were you going to say something?
No, I was just going to ask the next question, but jump in, Bethany. And then...
I don't have much to add. I am thinking about all the things that I've heard people talking about, the things that they grieve. And I'm always going back to assumptions in these conversations, but I think it is easy for people to assume that life will be better after resettlement in the United States. And that's not often the case. I know one woman, for example, that we worked with used to have drivers and several houses and used to be very wealthy in her country of origin. And she lived a very comfortable life that way. And we make these assumptions about when we hear the word refugee, it's easy to make assumptions about what that means and where people are from and what their life used to look like. And so now they get this house and they get this, they get government assistance, but that doesn't mean, first of all, it doesn't mean that they now live a cushy life, but it especially does not mean that their life is better now. And so that grief can take all kinds of forms. You asked specifically about stages of grief. And this is definitely, I would call, a complicated grief process, because you're constantly grieving, because you're constantly on the move. Things are constantly changing, much less thinking about the things that you've lost along the way at every stage. And so there are lots of factors to take in when we're talking about grief. It's not just the overall loss of people and things and places, but it's that consistent loss and moving and then losing things again and again. And then a whole different subject is the grief over the sense of identity and culture as well, which is its own process.
Yeah, and Bethany's touching on a pet peeve of mine, which is the expectation of gratitude from refugees who are resettled in the United States. That idea that if you are processing grief, if you're sad to be here, if you're angry, that you're not allowed to have those emotions because you're so lucky to be here. Why aren't you grateful? And especially for future clinicians, medical professionals, healthcare professionals, they're letting go of that American exceptionalism that says like anyone would be lucky to live in the United States. People should be grateful to be here. That's a huge like personal barrier to being able to understand someone's or hear someone's experience, right? If when I'm working with people, if they're coming to me and they're saying my apartment is horrible, it's like roach infested, I can't live here. And if my assumption, and this is the reaction that some people have had when resettling refugees have broached these topics, they say, well, it's better than what you had before, right? You're safer here. You should be like, stop complaining about it. And so giving people space to not like the position here. They didn't choose to have to leave. They didn't choose to be their country of resettlement, and letting people have space to grieve and to be mad and to experience or to manifest grief in all those different ways that Bethany's talking about, that it may not look like the way you want it to look as someone who has been born and raised in the United States.
Okay, thanks. So David had a question that I'll read. Oh, Ashley, did you want to jump in there on that?
That might be easier. I didn't mean, you'd think I'd have learned Zoom chat better than I have over the last year, but.
David, can I ask you to hold 1 second? Because I think Ashley had a follow-up on the grief thing, and then we want to go to you. Oh, no.
I have a completely different question, so we should go ahead and let David ask.
Okay, go ahead, David, and then we'll get back to Ashley.
So yeah, this is for everybody, but for Bethany and Katie, your organizations are partnerships. And so I wonder if you could talk a little bit about, the partnerships that you're drawing on that as it relates to this issue, the medical community, the mental health community, and what's kind of the state of partnerships and collaborations coming together around, trauma for refugees and so forth in the Newer Valley and in Roanoke.
Yeah, I think Eva would also be a really good person to answer this question with the Refugee Mental Health Council. Eva, do you want to talk about the council, and then I can talk about more locally?
Okay, thanks, David, for that question. I work for a statewide refugee program, and I kind of coordinate. I coordinate local mental health councils, and one of it is the Roanoke Refugee Mental Health Council, which that's the first time I met and was introduced to Bethany. And also that's the reason how I met Rebecca here and Katie as well. So Roanoke Refugee Mental Health Council was established in 2015. And it's a very active and dynamic council. All the people involved running the council are volunteers. They represent different organizations, and we have accomplished a lot based from Roanoke Refugee Mental Health Council. One of it is our yearly annual conference specific to refugees, refugee mental health problems, refugee mental health issues. It's our way of connecting with our stakeholders and supporting them, and as well as giving them the opportunity to let us know what your needs at your level, so we can advocate and bring this information to our leaders, you know, at the upper level. So we have done a lot with that. The second, that the Roanoke Refugee Mental Health Council has contributed to the overall program at the state level, is the development of the Virginia Behavioral Health Interpreting Curriculum. How it started really was in Roanoke, where I have 5 clinicians in the council, and they just simply put it straight in my face and say, Eva, I want to help the refugees, but I do not talk their language. And if you send me an interpreter, I don't trust those interpreters. They could be trained, they could be untrained. I just don't trust them. In some way, I heard them say these things, and I don't think they can accurately transfer the message across, my message across. And so with that, I was just thinking, let's create something for the interpreters, so that we can help the refugees connect with the clinicians. Lo and behold, that was the beginning. And now we have the Virginia Behavioral Health Interpreting Curriculum. We have trained over 200 behavioral health interpreters, and we are going nationwide. Our webinars we have a series of webinars. We have 3 webinars starting January, and we are able to reach out to at least 38 different states and 13 different countries. So that's how important the Roanoke Refugee Mental Health Council and the contributions of our partners. There are some more, but those are, I will take 2 hours just to explain the Roanoke Refugee Mental Health Council, but I'll just, one more clarification. Why is it called behavioral health interpreters? Because our interpreters are trained in a medical setting, and what they learn are the biology. In mental health, you don't talk about biology, you talk about trauma and depression. And those are things that we don't have imaging to support it. We don't have lab works to support it. And so these interpreters, and according to law, qualified interpreters must know the field of which they are interpreting, which is mental health, different from physical health, and the vocabulary and phraseology. In behavioral health, we are bombarded by culture. And so culture is an important component in that interpreting piece, as well as the ways by which we construct the standards of practice is different. So I just would like to put it there to tell you that there is a big difference when the interpreter is a trained behavioral interpreter serving in a behavioral health setting versus a medical interpreter or a court interpreter going into mental health setting. The rest, Bethany, it's yours. Thank you for your graciousness to share the Roanoke Refugee Mental Health Council from the perspective of the state.
David, asking about connections and collaborations, I think the main one that we are always in connection with is our local resettlement agency, Commonwealth Catholic Charities, because they are going to have the most information on the people who come in who are resettled. So having a great partnership with them and being in contact with them and always making sure that we are fostering that relationship is really important. And then we are also a part of the local dialogue group for refugee issues. And that dialogue group has been really integral because it brings everyone to the table. So we have mental health organizations, resettlement organizations, medical people in the medical field. We have essentially people from all quadrants coming in to sit at the table and talk about refugee issues, what's going on in the field, what's going to happen with resettlement, for example, where the United States is going to resettle more refugees than ever. And so what does that look like for us locally and statewide? Having those conversations so that we can have a plan, and continuing those conversations around collaboration is really important. Also at a research level, I think Rebecca can speak to the different research projects that are going on and the different coalitions that have formed around that as well.
So we just have 2 minutes, and I wanted to get Dr. Shu's question out there so that we can wrap up on time.
I think it's a pretty quick question. I'm wondering how to bring awareness and some depth to conversations that students have about these things. So I think, we're teaching pre-health professionals in medicine and society to know, like, I have a list of books for kids. Like I read, or when my kids were a little bit smaller, I read things like The Lost and Found Cat, right? Which talks about this cat that was like lost as people are migrating. And then eventually it's a story about a cat, but like the background is this migrant refugee story that's happening, and they found the cat, everyone. I've read things like Exit West, a fictional account that involves displacement in different ways. But I'm wondering if you guys have any like reading recommendations in poetry, literature, fiction to help supplement people's imaginations on these topics.
Go ahead, Eva.
The Roanoke Refugee Mental Health Council has developed 6 kids books. No, it's not really kids book. It's like a 2-page, 4-page that kids can work on. I can send that to Rebecca and she can share it with you. That's a very good resource. Sorry.
Yeah, similarly, I have graphic. There's like a rising trend in like graphic formats, right? Both in medicine, graphic medicine is like a really popular thing right now, and also kind of graphic refugee narratives, and not graphic as in like explicit, but like illustrated. And it's it's not just for kids anymore, right? Comics, they're like geared toward adults, and they're geared toward these difficult conversations. And I have a list. Katie Powell, who's also on the call, has like many different like refugee narratives that she has collected. And then also one book I taught in literature, medicine, and culture is The Spirit Catches You and You Fall Down by Anne Fadiman. And she is not refugee background. And some people have sort of like, it was written back in the 80s about like the Hmong refugee crisis. And some people have since sort of like, kind of raise some eyebrows about it. But I feel like for students, especially, it's a really good insight into the ethical issues of physician, like Western physician meets refugee, and how communication breaks down, how it doesn't happen, how assumptions are like lead to really sticky situations and really horrible situations. And that was a really popular reading with my students, and I think really helpful.
Did you want to add any, Bethany, before we wrap up? Okay. Well, I want to thank you all for attending this Medicine and Society mashup, and for your questions and contributions. Thank you to Eva, Bethany, and Katie for taking the time to share your expertise with us. And please go to the Medicine and Society blog at VT. You'll find a recording of this and other events that we've had before. And stay tuned for other events we'll continue to have at the intersection of medicine and society. So thanks, everybody. This concludes today's event, and I hope to see you all again very soon.
Thanks, everyone.
Bye, guys. Sorry, Ken.
Hi, I think I got here late.